Fellow. Thank you everyone for attending today's seminar. I hope you all take the most out of it and you all enjoy our speeches. And thanks, of course, to our speakers for joining the meeting today. Before we start, I just want to let you know that Dr. Michael Onwukbufor won't be able to join us, unfortunately, because he had a last-minute call. And unfortunately, yeah, he cannot join us. I also wanted to let you know that we'll be taking questions at the end of the session, and the Q&A session won't be recorded, so just feel free to express any thoughts or questions like freely. And I guess we can get started. So we could start with our first speaker for today, Dr. Nicole Mahdi, from Neurology Department at Sinai Hospital of Baltimore. Thank you, Dr. Mahdi, for joining us today.
Glad to be here. Good evening, everybody. Thank you for having me. You want me just to share my slides and roll on?
Yep.
Okay, so I'm going to share my slides. Are you guys able to see them? Let me go backwards. Previous. You guys can see it okay?
Yep, we can see them.
Yep. Okay. Well, hello, everyone. My name is Dr. Nicole Mahdi. I am a vascular neurologist at the Sinai Hospital of Baltimore. I serve as the stroke medical director there. And what I was going to do, it sounds like we were told to give you guys a little insight about what exactly I do, the path to get there, and get a little bit of information on how I got here. And then for sure, if anyone has any questions about the field of neurology or even my subspecialty, I welcome them. So this picture actually to the right is, I actually was very honored by LifeBridge Health is the hospital system that Sinai is under. For those of you in Baltimore, you may have even rotated at Sinai, or you've heard of Northwest Hospital or Carroll Hospital or Levendale or Grace Medical. We're all under the LifeBridge health system. They actually featured me in Baltimore Magazine because they do a physician feature every month. This was, I guess, a couple of years ago. Which was very gracious of them. At that time, actually, I was a stroke medical director at Northwest Hospital, but last year I was promoted to the stroke medical directorship at Sinai, since it's a larger hospital and a bigger program. So in general, what exactly does a neurologist do, right? So you break it down, of course, a neurologist studies the neurons. So we are brain doctors, as I call myself in the community, since that makes it a little bit easier for folks not to confuse us with urologists, which happens more often than you think. And so in general, basically my job, I study disorders of the nervous system, both the central and the peripheral. So everything from your brain and your spinal cord down to the nerves that go out to all of your muscles. And as a neurologist, just so you understand, the training is different than if you go into pediatrics. So I only take care of adults, so 18 and up. A pediatric neurologist takes care of nervous system issues, but only in children and teenagers. And the training is totally opposite. You have to make a decision at the door whether or not you want to do pediatrics or adult neurology, because the training programs are completely separate. You can't kind of do neuro and then say, I want to take care of kids. It kind of doesn't work that way. Because little do you know, children are not just little adults. So, and I'm sure my other colleagues on the call can attest to that. So pediatric neuro is a whole nother bucket of knowledge base that I don't need for the boards, but outside of that, I don't need it for my practice. And so you've probably heard of some of these conditions before, between either you've had family members that maybe have these, you've seen commercials, or you've seen it in your studies. Some of the common neurological conditions you've probably heard of: Parkinson's, multiple sclerosis, stroke, which is what my specialty is. As a vascular neurologist, basically, quote unquote, I'm a stroke doctor. Epilepsy or seizures, migraines. You may have migraines yourself. Everybody knows somebody who suffers from migraines. Alzheimer's disease, myasthenia gravis. Those are just some examples of neurological conditions that neurologists may take care of. And so specifically the steps to get there, before I get into more of the details, is you got to get a college degree. And then after college, and you don't have to go straight from college into medical school, as everybody knows, some people take breaks. You go to medical school for 4 years. At that time, you have to make your decision on what specialty you'd like to do, which is usually by your 3rd year. And then you apply for residency. Neurology residency, which is now after medical school, you're a physician, but you're a training physician. And so residency is that time where you're trained to actually physically take all the knowledge you learn in medical school to physically do that practice with real human beings and patients. And you are a doctor at that point, so you have privileges, but you're overseen by an attending physician or a fellow. And it's total of 4 years, with 1 year of that 4 years being an internal medicine residency. There are several specialties that require you to do 1 year of internal medicine, because we have to forget neurological patients or psychiatric patients, or you can go down the line. Everyone also has general medical problems. So getting a baseline understanding of just regular medical management is also important in being a subspecialist. So it's required that you do 1 year of internal medicine residency. Then after that, you go on to do 3 years straight of neurology residency, where you will go through every single aspect of the nervous system possible. And similar towards the end of medical school, towards the end of residency, you have to make a decision on what type of neurology you'd like to practice, if you'd like to go into general practice, or you'd like to subspecialize. And if you decide to subspecialize, that will require you to do the next step, which is fellowship. Fellowship in neurology is anywhere from 1 to 2 years, depending on what you choose. Other subspecialties are longer in other specialties of medicine. And as a fellow, you technically are attending level, but since you're in the additional level of subspecialty training, you still have preceptors that are attendings that are overseeing your work, but you have way more autonomy that you had as a resident. Because if you never went to fellowship, you would be in attending somewhere. And within that period of fellowship, usually is the time where most people take their boards. And then after that, if you do a subspecialty training, you have subspecialty boards, and that allows you therefore to be board certified in what you do. Some jobs, some hospitals, I think a good chunk of them either require or prefer you to be board certified rather than just have training, graduation. So I think most people try their best to get their boards done and completed and passed before they start a new job. But for example, if you go from residency straight to practice, you may not have quite taken your boards yet. The advantage of me being fellowship, I took my neurology boards while I was a fellow. So by the time I had my job, I was already board certified in neuro, and then took my vascular neurology sub boards after that, since those are every 2 years once I finished fellowship. Neurology has a robust amount of subspecialties. To me, neurology and internal medicine are very similar, where you can say you want to be a medicine doc and then you decide I want to do heme or nephro or cards or GI, and you could just spread your wings to where you want to be if you don't want to be an internist. Neurology is the same way. You can spread your wings in so many different directions on how you want to take care of patients. Or you can say, I just want to do general medicine, or be a neurohospitalist, which means you take care of everything that walks in the door, or you have a private practice where you just see outpatients for all types of neurological conditions. So my specialty is vascular neurology. So what I do specifically as a vascular neurologist, in general, I take care of stroke patients. So all types of strokes, bleeding strokes, ischemic strokes. I have involvement in different types of both of those strokes. So anything around a stroke is what I specialize in. Specifically, my job at the hospital is I do both inpatient practice and outpatient practice. It's about 50-50. So for the most part, I rotate and cover 2 hospitals physically, one where we have our own inpatient service, where I run the stroke service. The other hospital, I'm a consultant, and I take care of everything while I'm there, sort of like a neurohospitalist, but specifically I am on call for only stroke emergency. So I take call about once a week at night from 5 p to 8 a at home. I do not have to go into the hospital. Where I am on call, I cover technically 4 internal hospitals, but by definition, University of Maryland, Johns Hopkins, St. Agnes, Franklin Square, or anybody in Baltimore, if they need us because their hospital is full or they don't have space, if they need transfer for acute strokes care, I take those phone calls. And that's about once a week and usually about once a month, but actually now my schedule is a lot better. I actually am kind of on call once every maybe 2 to 3 months on a weekend, since we have enough bodies to cover the service. And so that's my inpatient life. My outpatient life is I'm in outpatient clinic this week. I see patients from about 8 to 4 with a lunch break between 12 and 1. And basically, my job is to see people that have just left the hospital and had a stroke and do their continuity of care afterwards, or learning about new people that I do get a lot of referrals from other hospitals, Hopkins, Maryland, any hospital in Baltimore who needs to see a stroke specialist. We see anybody. You do not have to be a patient of Sinai or LifeBridge in order to be seen in our clinic. So I see patients that have had, actually, I just saw a patient today who had a stroke and they were at Maryland at the time. So we're open to anybody. So that's sort of how my, normal daily practice is. Depending on what you choose to do from a subspecialty, your life may be different. So things like on that neuromuscular is where you hear about some things like myasthenia gravis. It's the study of the nerves and the muscles of the peripheral nervous system, not the brain and the spinal cord, basically everything that comes out of that. Their lives tend to be a lot more relaxed because they don't have as much inpatient responsibilities or emergencies. Neurocritical care, it's basically you're an intensivist, an ICU doctor, but all you take care of is neurological emergencies that require ICU care. Typically, ICU docs are 7 on, 7 off. So you work 1 week in the hospital for a week, and then after those 7 days, you get a week completely off. But you're on call 24/7 for that week. So some people like that lifestyle. Some people don't care for that lifestyle. Headache is also a lot more relaxed in terms of probably most headache specialists are all outpatient and rarely do any inpatient medicine, but their clinics are quite stacked because they see a lot more patients in a small period of time. And basically they're taking care of chronic pain, which has your own other dealings with. Epilepsy or seizures, you also can do similar where you're on call for inpatient and outpatient practice. Clinical neurophysiology is an overlap between neuromuscular and epilepsy. So part of seizure care is doing an exam called an EEG that looks at brain waves. And part of neuromuscular is doing an exam called an EMG, or a nerve conduction study that looks at muscles and nerves. So clinical neurophysiology residency and fellowship allows you to actually kind of combine both, more so understanding the underlying neurophysiology of those two conditions. So a lot of people will end up doing clinical neurophysiology, and that'll allow them to be able to put themselves in either specialty if they choose to. Neuroimmunology is things like multiple sclerosis, where medical conditions that attack the nervous system, and movement disorders are things like your Parkinson's disease, dystonia, tremors. They also tend to be majority outpatient practice because they don't truly have a lot of inpatient neurological emergencies. And then neuro-oncology, which is those that take care of cancers involving the spine and the brain. And for my path specifically, so I went to undergraduate at Howard University, spent 4 years there, was a bio pre-med major, then went to medical school at University of Maryland, and then did my internship at Mercy in Baltimore, and then went to Philadelphia and did my 3 years of neurology residency at Thomas Jefferson, and then went to Atlanta and did my vascular neurology fellowship for 1 year at Emory, which means you basically also are a Grady doc. And then currently, literally the job that I'm in right now is my first job straight out of fellowship. And I'm still here and I don't have any plans to leave because I thoroughly enjoy the people I work with and my lifestyle. So I think that sums it up. Is there anything else specifically you wanted me to talk about before, I guess, questions? I don't know if we're doing questions now or we're going to wait till all the way at the end.
Well, thank you so much for your talk. I think we can do the questions after the second speaker. We can combine the questions all together, if you all agree.
Sounds great. I will, let me exit, let me unshare. Stop share. There we go.
Okay. Thank you so much again. So I guess we can move on to our next speaker for today, Dr. Jana Christian from Hematology Department at Johns Hopkins. Thank you so much, Dr. Christian, for joining us today.
Sure, very happy to be here. All right, let me share my slides. All right, does this look okay? Is this in presenter mode for everyone? Okay, excellent. So hello, everyone. Very happy to be here with you all today. My name's Jana Christian. I am a hematology fellow at Johns Hopkins, and I'll be sharing about my specialty, hematology. So first, what is hematology? So hematology is a subspecialty in internal medicine, which we'll define a little bit later on. And it's focused on the study of the causes of treatment and prevention of diseases related to the blood. And specifically, I am a classical hematologist. And specifically what that means is that I specialize in the care of patients who have blood disorders that are not due to cancer. So not leukemia or lymphoma. So then what are the disorders that somebody who does classical hematology entail? So on this slide, I just included three of the most common disorders that we see as hematologists. Some of these you may have heard of before, some of these you may not have. So first category is bleeding disorders. One disorder in that category is hemophilia. So hemophilia is an inherited bleeding disorder, happens in boys and men, and it leads to, as we see in this picture, very painful and spontaneous bleeds that can occur in large joints like the knees and the hips. And with proper care with a hematologist, we can prevent that bleeding if at all possible. And if we're not able to prevent all bleeding, we can certainly treat it effectively. Then we have hemoglobin disorders, one of which is sickle cell disease, which is a very common disorder that people may know a lot about. So sickle cell disease is a disorder of the red blood cells. So we see here in this picture that the red blood cells normally have this nice round shape, but in sickle cell, the red blood cells have this unusual or sickled shape. And this sickled shape, when it occurs, and especially in certain episodes where the sickling worsens, that can lead to blockage of blood flow, that can lead to dysfunction in our organs, as well as really painful pain crises for these people. And then finally, the last category of just some of the common disorders that we treat as hematologists are blood clotting disorders. So here's a picture of someone with a deep vein thrombosis, which is a blood clot that's formed in the veins of the leg. And it presents with some swelling in the leg, pain, redness, and then pulmonary emboli, which are blood clots in the lung, can be a life-threatening disorder that presents with chest pain and trouble breathing, and also with the help of a hematologist to diagnose it and to figure out why this occurred in the person and the appropriate treatment. And then another thing hematologists are experts and specialists on is how to look at the blood smear. So we are experts that we can, have our team draw blood from a given patient and look at that blood under the microscope. And here on the left of the screen, we see what should be a normal blood smear that we would expect from a person who doesn't have an underlying hematologic condition or an underlying problem with their red blood cells. And you see just beautifully shaped red blood cells with generally mostly red color with a small amount of central whiteness, which we call central pallor. And then if we look to the right in comparison, you can probably tell that this image on the right looks very different than the one on the left, where we see that the red blood cells are certainly more white than they would be red. And you also see that there's something indicated as a pencil cell, where the red blood cell has completely lost its round shape and looks more elongated. And I promise you, if you showed this blood smear to any hematologist before even showing them labs or describing the situation of the person, they could easily diagnose this as a blood smear of someone who has iron deficiency or not enough iron in their system to contribute to the red blood cells being formed. So how did I learn about hematology? So as we were discussing, there's a long path from hematology from college to practicing, and in between those two steps involves going to medical school for 4 years, doing residency practice, and then for hematology in particular, it would be internal medicine residency, followed by fellowship training in hematology. And internal medicine residency training, just as similar as we were talking about for neurology residency training, it provides you with that foundational, comprehensive knowledge of all these general medical conditions. And then it also allows for tons of exposure throughout your 3 years of residency training to all the different subspecialties within internal medicine. So that includes pursuing general practice, where you don't need to do any further training after residency, becoming a heart specialist with cardiology, becoming a kidney specialist with nephrology, specializing in the lungs as a pulmonologist, et cetera, et cetera, et cetera. And of course, hematology as well. So when I was a second year resident in internal medicine residency, I remember rotating throughout all the specialties, rotating in the ICU, taking care of patients who were critically ill, learning about how to care for patients with kidney disorders. And in my second year of residency, I rotated on the hematology service as an elective. And I remember meeting the physician who was a hematologist, who was incredibly brilliant, hardworking, had wonderful relationships with the patients, was really quick to make really complex and interesting diagnoses. And I think most people feel this way about their field, but from that experience in second year of residency, I was hooked. And I want to emphasize that to also say that, some people know when they're starting medical school what they want to do, but some people need to go through medical school and almost half of their residency training or more to really hone in on what is interesting to them that they want to pursue as their career. And that's what happened for me. So why do I love hematology? So I believe in hematology, there's the opportunity to be a detective and an investigator, which I've really loved and enjoyed the field. So you may have a patient who comes in the clinic or presents to the ER in the hospital, and all of a sudden they're having significant bleeding, and they don't have an inherited condition that they've known about or a reason to have all this bleeding or a certain medication. And you have to figure out exactly what might be going on for why all this bleeding is occurring and what the appropriate treatment is. And then for the patients who, say, are born with a disorder like sickle cell disease or hemophilia, then you have the opportunity, of course, these patients need to be followed throughout their lives with a blood specialist who knows how to address their care and make sure that as there might be hiccups and issues along the way, that they're getting appropriate treatment. And so in that way, in hematology, similar to a lot of other specialties in internal medicine, you have the ability to develop long-term relationships with patients as you see them months on end, years on end for regular visits, following up with them. And then I think many people will feel this about their specialty as well, but in many instances in hematology, for example, for the blood smear that I was showing you with a person with iron deficiency, these patients can come in feeling very, very short of breath, very exhausted, high heart rates, severe fatigue. And with a few treatments of iron, either through the mouth or through the IV, they feel a million times better. And you can really help people feel just better in hematology. And of course, in hematology and all specialties, there are some times where you can't make the patient feel better completely and can't provide the cure, but being able to help is obviously the privilege of hematology and all of these medical specialties. So to be a hematologist, and we've covered this a little bit already, so we can go through this very quickly. I'm not sure. I know people are at different phases of their path in medicine here today. So some people might have already done their pre-med requirements in college or through a post-bac program. Some people might have already taken the MCAT, applied to medical school, be in medical school, but medical school is subsequently 4 years. Then internal medicine residency in particular is another 3 years. And then most hematology fellowship programs, if you're interested in being a hematologist, are actually combined with medical oncology fellowships. And in medical oncology is a study of cancer, including both what we call solid cancers, which is prostate cancer, breast cancer, gastric cancer, colon cancer, as well as the blood cancers with leukemia and lymphoma. So in our Q&A session, I know we're going to talk a lot about any questions that you all have. And I wanted to start this by being very forthcoming about some of the challenges that I've personally encountered during my training or my journey in medicine, to hopefully normalize them for you and hopefully then create a safe space for any discussions that you guys would like to have, because we really want to make sure to answer any question or concern you all have. So with that, let me tell you a little bit about my challenges so far. So I was very lucky for college to go to Harvard, to go to an incredibly prestigious college and university. But prior to going to college, I had gone to a small private school where my graduating class was 60 people. So I was very used to very small classes, really individualized learning, appropriate attention. And college was nothing like that. Incredibly big classes, hundreds of people in one class, difficulty with lecture-based learning. And I really struggled my first year or two in college, getting the grades that I thought I should get and doing well in my pre-medical school classes. Then when I went to take the MCAT, the first time I took the test, I got my score, and it was a score, but it wasn't a score necessarily that I thought could bring me to the medical school that I hoped to go to and the training that I hoped to pursue. And so I just sat down and studied 10 times harder and took the MCAT again, and then was able to get a score that I really was able to feel proud of, but sometimes you need to try again and take a test or take a class or whatever again, and knowing that that's normal and part of some expected challenges. I've also been lucky to go to a number of wonderful different training programs for medical school, for residency, and now for my fellowship training at Hopkins. But for each step between medical school, residency, and fellowship, I've actually been to a different city and state. And for some people, that might be a wonderful adventure. But for me, it was hard to leave the friends and family and routines that you would establish in a given city to then pick up and move. But to get this medical training, sometimes that is part of it, is moving to the institution that's going to best fit your needs in terms of your academic and medical journey. And then certainly, as you guys probably know, it's lots of long hours in the hospital. You might miss certain events with loved ones. And this is also kind of the give and take of early training in terms of residency and fellowship can sometimes be intense. So then what do you do about these challenges? So, I share some of my personal challenges, and I'm sure I have more, to say that they're normal and that they should be expected. And with lots of help and asking for help, you can do this. And so throughout my medical training, I've leaned on my family, my friends, colleagues, mentors, because it really does take a lot of help and grit to get through this. But then, as I hope we'll share today, it's ultimately really rewarding and lots of fun to be able to take care of patients. So that's all I have for you guys. And lead it to you, I guess, for Q&A.
Thank you so much, Dr. Christian. This was a really enlightening speech. Thanks again.